Okay, thanks, Mark. As Mark said, there will be a degree of overlap in this, and obviously I could talk about zygosity and chronicity in about 30 seconds, and so there will be a degree of overlap between our two talks that we've already been through. But one of the questions is, why is multiple pregnancy important? Why are we interested in it? Well, we all know that pregnancy puts a significant strain on the physiology of women, and particularly women with heart conditions, and multiple pregnancy adds to that strain. So that's our first problem in reality. The second thing is actually it puts quite a logistic problem for us. So when you talk about higher multiple pregnancies, there are all these strains on organisation and on maternity and neonatal services. And in fact, this is our unit a few weeks ago where we were trying to set up for a caesarean section for quads. And you can see all of the neonatal unit that we had to put in a room adjoining the theatre to resuscitate all the babies, and then we had to find 4 cots for them all. But we've got to remember that actually these bring significant joy to the parents and to the sibs, and we shouldn't get carried away with the pathology of it all the time. So, the geography of the prevalence of multiple births is quite interesting, and Mark's mentioned this already, and it's higher in the States than it is in Europe. It's highest in Africa. But one of the really interesting things is that if you look in the States, actually there's no difference in between the different ethnic groups. So regardless of whether your ethnic origin is Hispanic or from Africa, once you've been living in the States for a while, all of these people have the same risk of multiple birth. These are our main risk factors, really. We mentioned them about maternal age and parity, but without doubt, the single biggest risk factor for multiple birth, especially higher order multiple births, is artificial reproduction. In the UK, we've seen a significant increase in this, by about 50%. It's even more in some areas of Europe, like the Netherlands. And then this increase in triplets that Mark mentioned is also been significant. So since this period of time, we've had an annual increase, a decrease in triplets, and this is mainly due to different techniques. And in 2011, there were 3 sets of quads. Now, this seems to be changing more recently, anecdotally. We certainly feel it is, because we've had 2 sets of quads over the summer. And on liaison with other units across the country, we know that many of these people are getting artificial reproductive techniques in foreign lands, having multiple embryos put back, and then they're coming back. In some centres, they're undergoing selective reduction. In our centre, these women declined that. So when we get to zygosity, so are these twins monozygous or polyzygotic? So in the UK, about a third of all multiple births are monozygous. So that gives you a prevalence of 2% of all births are dizygous and 1% are monozygous. With artificial reproduction, predominantly we end up with dizygous births, and so that's when you put back more than one embryo. But the rate of monozygotic twinning is also increased by about 5 to 10%. 5 to 10 times, sorry. You've got certain things have changed this throughout the UK, where now we promote single embryo transfer. Single embryo transfer does decrease the rate of multiple birth, but what it does appear to do is it slightly decreases the success rate. If you talk to people that go to different centres, some centres will promote the advantages of having more than one embryo put back. People look at embryos, grade the embryos, and sometimes think that they're not high quality embryos and promote the fact that you should have more than one put back so that you increase your chance of birth of a single fetus. But often you'll end up with twins with this. More recently, we've got delayed embryo transfer. And if this is occurring later, the delayed embryo transfer, there's some dispute about whether there's an increase in monozygotic twinning or not associated with this. A Cochrane review has said not. However, more recent evidence would suggest that there's actually a doubling of monozygotic twinning with this technique compared to day 3 transfer. So, what is the relationship between chorionicity and zygosity? I'm sure many people know this, so what you have here is, depending on when, these are all monozygotic here, so depending on when you have your embryo splitting, you can end up with a dichorionic diamniotic pregnancy with a fused placenta, with separate placentas, or then you can end up, if embryo splitting in a monozygotic pregnancy occurs between days 3 to 9, you end up with a monochorionic diamniotic pregnancy. And these are the ones that we see in significant numbers and the ones that have significantly higher risk. Monochorionic monoamniotic pregnancies are at higher risk still, where you get division slightly later, between 9 and 15 days. However, they're much rarer. Here's just an example of a placenta with a monochorionic pregnancy. And the reason that monochorionic pregnancies are at higher risk is because of these anastomoses between the two circulations that are pointed out, which effectively means the blood circulation of the two fetuses are joined. Sometimes, if all the anastomoses are balanced, that doesn't matter, but in a proportion of babies, these will be unbalanced, and then you get fetal-fetal transfusion syndrome. And the other problem these face is if you have single intrauterine death. So if you have single intrauterine death, and you have these, regardless of whether these were balanced or unbalanced at the time, then you'll have a lower pump pressure on one side of the anastomoses than the other, and there's a significant risk of the other twin dying within the first 24 hours, and a risk of significant neurological deficit as well in the longer term. So this is our problem of monochorionicity. So, if we look at the relationship between zygosity and chorionicity, we know that looking at dizygotic twins, so twins that are non-identical, about half of them will have separate placentas. About half of them have a fused placenta, and of course none of them are monochorionic or monoamniotic. If, however, you look at identical twins, so monozygotic twins, about a fifth of them are dichorionic with separate placentas, 10% of them are dichorionic diamniotic, and then 60% of them are monochorionic, with a small proportion being monoamniotic as well. So often, people look at babies that are dichorionic and talk about them being dizygotic, but that's not necessarily true. The only way, really, to determine zygosity is by DNA fingerprinting, and that's rarely done. Chorionicity, however, as we've already mentioned, is one of the most important things. And chorionicity can be determined by ultrasound, and you could determine it back in 1994. It was suggested doing this by a mixture of gender placental masses, because if you have more than one placental mass, you have to be dichorionic. The thickness of the amniotic membrane, and as far back as 1981, the T and lambda signs were written up, and most of us think of this as being a relatively new thing. So, here's a couple of ultrasound scans where you've got placental mass here and here, with a fetus in one gestation sac there, another fetus here, and again there and there. In this slide, you can see you've got a thin membrane that goes on and joins the placental mass there with a T sign. And here, you've got the chorion from both placentae growing up inside this thicker membrane. And you get the lambda sign. So this would suggest that these are dichorionic, and these would suggest that they're monochorionic. This sometimes is more difficult to determine than that. So if you see this, you're relatively sure that they're dichorionic, but really getting the right views, sometimes you can be fooled and think that these are monochorionic. So, if you look at the literature, actually there's very little literature out there that talks about how to determine chorionicity. And if you look at the number of cases in these, and this was taken from the NICE guidelines in 2011, you can see that each of the studies has a relatively small number of babies in it. What we do know is if you just go by the lambda or T sign, you can have, it's not as accurate as using multiple indicators. So as you use more and more indicators, the sensitivity of determining monochorionicity, which is what we're really interested in, and the specificity increases to the point whereby if you use placental masses, a lambda and a T sign, membrane thickness and gender, then that will give you the highest sensitivity and specificity of determining chorionicity. With these best being performed in the first trimester, and this being additional later. So Mark's already mentioned that monochorionic twins have an increased perinatal risk, and this graph really does show this quite nicely. So this is the reason that it's important, because actually it does change our management. And these are the reasons why. So if you compare singletons to twins, so you're more likely to miscarry if you have dichorionic twins, and you're much more likely to miscarry if they're monochorionic. Again, perinatal death after 23 weeks increases, fetal growth restriction, preterm delivery, and major abnormalities. This one, of course, is per baby. And that's something that we'll talk about in more detail later. But when people talk about there's a 1% risk in dichorionic twins, of course, it's a 1% per baby, not 1% for the whole pregnancy. So overall, we know that congenital abnormalities are more likely to occur in twins rather than singletons, and they're 4 to 5 times more likely in monozygotic twins. Which abnormalities? Well, CNS abnormalities, including neural tube defects and cardiac abnormalities, appear to be really key. And one of the things that we're not particularly good at still is determining cardiac abnormalities. So these increased risks of monochorionicity, once we know that a pregnancy is a monochorionic pregnancy, we can change things. So we can change our monitoring. So NICE guidance would suggest that these babies have fortnightly scans for fetal transfusion syndrome. And we can change our management. And we can change our management because you might determine if a baby's growth restricted and premature, for example, you might determine whether you would deliver them, might change whether they were dichorionic or monochorionic. If they were dichorionic, you could have a discussion with the parents of the benefits of delaying delivery for the well baby may be higher than if they're monochorionic, because if the baby that's unwell dies, then it has a significant impact on the other baby as well. And these are things that the couple, difficult conversations to have with couples, but they're helped if we do know the chorionicity. So, in summary, about 70% of pregnancies are dizygotic. 70 to 80%, we determine zygosity and chorionicity. The detection rate of whether they're monochorionic, which is the thing that we're interested in, we're not really interested in determining dichorionicity, is best achieved at 11 to 14 weeks, looking at the lambda sign, the number of placental masses, and the thickness of the membrane. And if you're going to remember 3 things from this, I think what you should do is when you try and determine chorionicity in the first trimester, if you're unsure, get a second opinion. If you're still unsure after the second opinion, then these babies should be treated as if they're monochorionic. And the final thing is that it's important that you take a hard copy of the first trimester scan, and really that should be placed in the mother's notes. Thank you.